Good morning, welcome to UCLA. I'm John Moriarty from the Department of Interventional Radiology and also of Medicine, and what I'm going to do today is, over the next 20 minutes or so, talk a bit about something that we're pretty passionate about here, which is DVT. DVT are clots that can happen in your legs, in your belly, in your lungs, in your heart. And what I hope to share with you are some of the ways that we have been treating them, helping people who have either acute or chronic problems with them, and some of the nice, neat tips and tricks that we've kind of learned along the way. So a couple of housekeeping items before we delve into it. We'd love to hear back from you, get you involved. If you can, follow us on the Twitter, hashtag UCLAMDChat. That'd be great. Some of the devices, some of the procedures I'm going to talk about involve various different companies' devices. We are doing our best to bring you the most up-to-date equipment and procedures here in UCLA, and so we've partnered with several companies, and several of the companies you can see up here sponsor some of my research. And then we'd love to hear from you online, but we'd also love to see you in person. So if you would like to see us, contact us at any of our vein clinics here in LA. We have one in Westwood, we've got one in Santa Monica, and then a third down in the South Bay in Manhattan Beach. Call us at any time. It'd be great to meet up with you and hopefully help you out with some of the problems that DVTs, varicose veins, vein problems in general can cause. So over the next little while, I'm going to be talking about DVT. And DVT, deep vein thrombosis, are clots. And I'm going to try and explain to you what is a DVT, how big a problem it is, and then finally, how do we go about treating it now in 2016? So clots are normal blood that becomes aggregated together into large or small clumps. And they can occur anywhere in the body, but they most commonly occur in the veins of the leg. And you have a pretty complex venous system in the leg. The blood goes down in the arteries all the way to your toes, comes back up through veins in your calf, in your thigh, and all the way back up into your pelvis. And clots can form in any part of those veins. Now, when you're looking at this yourself, either because you've had a DVT yourself or you're looking around online, you're going to see various names for the veins themselves. The veins themselves are important, but it's more the group of veins that is most predictive of whether you're going to develop a problem and what sort of treatment you might need as well. So when you're examining someone who has DVT, or when you're looking out for what the best treatment might be for that person, we try and kind of risk stratify people into where their clots might be. So you might hear us talking about clots that are from the hip on up, which would be called an iliofemoral DVT. Somewhere from the hip to the knee then would be considered a femoral-popliteal DVT, and then from the knee down to the toes would be called a calf DVT. And in this way, we try and group people who have similar symptoms, similar outcomes, similar treatment patterns together. The veins of the legs come together in the pelvis to form the main vein out of the belly into the heart and lungs. This is called your IVC, or your inferior vena cava. And people who have severe clots, and we think that's about 3% of all people who have a DVT, can have clots within this IVC. And this is a severe problem because it affects all the venous drainage out of the legs up to the heart and lungs. And therefore, people who have clots within the cava, the IVC, can have severe leg swelling. And so there are people who develop clots there. There are people who are particularly prone to them. And there are ways that we have developed to either treat them or prevent clot from the legs moving through the cava up to places where it can cause this damage. And these would be things like IVC filters, which you can see here on the screen. These are small metallic cages that we can place into the vein that can prevent the clot from moving from somewhere where it's still dangerous, but to somewhere where it's life-threatening up in your heart and lungs. Excuse me. And IVC filters are a whole different discussion that hopefully I'll have with you sometime. They're a very important part of the treatment and management of DVT. Removing these filters is increasingly important with large filter clinics like ours, seeing people who've had filters for many years or filters that have become problematic. And certainly if you have a problem with an IVC filter or any questions about it, please contact us at the numbers that I gave you earlier on, and I'll give it to you again later on. The end result of a clot that is in the legs and moves through the cava is that it goes into the lungs. This is called a PE, or pulmonary embolism. And this is a potentially very dangerous scenario. This can happen to almost anyone, young, fit athletes. Serena Williams, Chris Bosh, they both had PEs and did well. But people can get very sick, and this can be a fatal event. Some of the techniques I'm going to show you, we also use in clearing clot out of the lung, out of the pulmonary arteries. So it's applicable to multiple different areas, but again, it's kind of a different topic that I just want to make you aware of, and that hopefully we'll talk about again at a different time. I told you that this is very common, and this is a problem that is increasingly recognized as being a major socioeconomic problem as well. So 1 to 3 of 1,000 people are going to develop this annually. So little under 1% of all of us are going to get one of these this year. That means there's almost 1 million cases in the US. Very, very common. It's the 3rd most common cause of cardiovascular mortality. So you've got heart attacks, you've got stroke, and then you've got DVTs, PE. The blanket umbrella term would be VTE, or venous thromboembolism. So this is not only a very common condition, but also a very dangerous one that can cause severe problems. If you develop one of these problems, you've got a 20% chance of dying within that year. So this is a very, very, very severe condition. Now, fortunately, if you are otherwise healthy, you tend to do very, very well. But the 20% of people who die tend to have other problems, such as they developed a clot and they also have cancer, or they also had surgery, or they also have a stroke. But it is a fact that if you have one of these conditions, a DVT, we really want to be watching you carefully, treating you aggressively to make sure that you get a very good outcome. Once you have a clot, and I see you in clinic, we tell people about the ABCs. So the ABCs of treating DVT are something that have been around for a while. They're changing, but they're very important. The A is ambulation, activity, walking. So up until recently, people who developed a clot within their legs would have been put into the bed, told to go to bed, stay there, that it's dangerous for you to move. We now know that that isn't the case. It's much more important that you're up, walking, getting going, getting the legs moving again, not only to prevent new clots from forming, but to prevent some of those other problems that can happen if you're bedbound, such as pneumonias, problems with infection. So we really want to get you walking. It's good for now. It's very good for predicting or preventing problems that could happen in the future as well. The B stands for blood thinners. This is the mainstay of treatment of DVTs for 70 odd years now. There are multiple different types of blood thinners that are very commonly used. You'll probably know a lot about them. Things like Coumadin or warfarin. Drugs such as heparin have been used for decades. And then there are also newer ones that are only coming onto the market now that have been specifically designed to help people with this problem. Drugs such as Pradaxa or Xarelto, Eliquis are only coming here in the United States in the last 5 to 10 years, but show a lot of promise for treating these sort of conditions. And then the C is compression. So after you've been told to get up walking, after you're taking your blood thinners, we want to then place you on compression stockings. And what these are not very attractive sometimes, but the stockings that you wear on your legs, they press the skin in to push some of that swelling that people often have up and out of the skin and into the blood vessels, so that it comes out of your body, out of your legs, into your body, and you can remove it that way. There's been some change with compression over the last little while. Up until recently, I would have said that everyone who has a DVT should be on compression for 2 years. They wear compression stocking or compression hose for 2 years from the date they get their DVT. There have been some trials recently, the SOX trial, that have shown that perhaps that isn't necessary for either as long or in everybody. But as of now, our recommendation is that in order to prevent downstream problems, we recommend you have the A's, the B's, and the C's all done together. But there is the ability and the need for something more than this. And so what are the different options for that? There are people who can't take blood thinners. They've either had a stroke, they've had a bleed into their belly because they have had an ulcer, they have certain genetic conditions. There are lots of people who shouldn't have their blood thinned. Are there options that we can give them? Yes, there are, and I'll be telling you about them in a minute or two. What if there's so much clot that the A, Bs and Cs won't treat all of it, that anticoagulation alone won't get rid of it? These are particularly people who have clot from the hip on up, as I was telling you about iliofemoral clot and also IVC clot. That's a large volume of clot that often won't break up on its own and needs a little bit of help from someone like myself. And then there's the way that we think that we can make people feel better quicker. In other words, when you get a clot and you go on what would currently be considered the optimum therapy, A, B, and C, is there something that we can add on to that that can make you get out of bed quicker, moving quicker, have less leg swelling, get back to your regular life, back to your regular work, back to your regular play quicker? If you're in hospital, get out of hospital quicker. Move along the kind of path to health as quickly as possible. And we think that there are some ways that we can help you with that. The final thing that we want to talk about are the additional things that we're going to be describing, techniques of removing clot, dissolving clot, are they better at preventing PTS? And PTS is post-thrombotic syndrome. This is something that is under-recognized, but a huge problem that is going to be very important for all people with DVT. Post-thrombotic syndrome, it has many names. It's also known as post-phlebitic syndrome or venous stasis syndrome. It's the most common complication of DVT. And what happens is that you get a clot in your leg, and over time, that develops a chronic, hard, firm blockage to flow. And when that flow is not good, downstream problems happen within the leg. And these can be from chronic leg swelling. Typically, the leg is big, fat, heavy. It is hot because it doesn't tend to sweat very well. It can be quite a lot of pain, particularly at night or after exercise during the day. People get edema, which is fluid buildup within the leg. They can also get skin changes, particularly on the inside of the calves, close to the ankle. These changes can be anything from discoloration to severe medical and surgical problems where the skin begins to break down with venous eczema or indeed a venous ulcer. And an ulcer is a terrible thing to happen. It's a breakdown in the skin which can then go on to have an infection and indeed can lead to a lot of tissue loss or even in the worst case scenario, an amputation. And PTS is extremely common. We're already talking about a very common condition, which is DVT, and this is a very common complication of it. Somewhere between 1.25% of all people who have DVT will go on to develop some form of PTS, despite being on the best treatment that's currently available. In most cases, it happens early. People who get a clot now will develop PTS sometime in the next 12 months, but there's a definite lag time. There are people who we see in the clinic regularly who have PTS now who had a clot back in the 90s. And so what we're going to try and do now is predict the people who have a DVT today in 2016 that need better treatment, more aggressive treatment, so that we aren't having problems in 2036. The numbers are, as I said, somewhere between 1.25% of all people with clot are going to develop PTS, and somewhere around about 5 to 10% of them are going to go on and have an ulcer. So putting that all together, of all the people who develop a clot today, that huge number, almost 1 million people in the States this year, about 5% are going to develop an ulcer over the course of their lifetime. That is a huge problem that is really going to need to be treated, not just on an individual patient basis, which is always our goal, to give the best patient care to you in person, but on a societal basis as well. Over 2 million workdays are lost because of leg ulcers in the US every year. Huge economic problem. When you take in the quality of life impairment, people who have heart failure, people who have emphysema or COPD, these are people who you would typically recognize as having severe quality of life impairments. But in fact, having PTS gives you as bad a quality of life impairment as those established conditions. And it's more expensive. If you have a heart attack, an MI or myocardial infarction, we estimate it costs you close to $10,000 in medical expenses per year. But if you have PTS, it's even more than that. It's about $12,000 per year. So we really want to try and nip this in the bud by being aggressive with our therapy in appropriate patients as early as we can so that we can prevent these downstream problems that can develop. So, not everyone who has a DVT develops clot. We're not perfect about predicting who the people who have a clot will develop PTS. But there are some people who we know are already at risk. So if you have obesity, if you have a smoking history, if you are older, or if you are pregnant, these are people who we know are going to be at increased risk of developing PTS, and we're really going to want to make sure that we take your care extremely seriously, because we know that downstream 10, 20 years, there may be problems related to that. So that's the background of all kind of DVT issues related to how often it happens, what the standard of care treatment is, what the reason that we think that we want to be a little bit more invasive is about removing clot. How do we actually go about it here at UCLA? Well, the first thing we do is, if you come into the clinic with a clot, is we want to confirm that it's there and its extent. And we do that by imaging. And we're lucky to have some excellent radiology faculty here who are dedicated to this. We start off with an ultrasound, which is a painless test available widely in the community. It'll show us the clots very well, typically from the hip on down to the toes. Excellent imaging of clots, such as you can see here on the screen. The next thing we would do is evaluate where else is the clot. For example, is it within the belly? Is it within the chest? And there are a couple of ways we can do that. A CAT scan is very good. Again, here in UCLA, we have some of the most up-to-date CAT scanning ability possible. This here would be one of our scanners in our Santa Monica facility. It's capable of scanning a 6-foot guy in 2 seconds. We can see the entire body, get a very good picture of someone with advanced clot like we had there. We can also do an MRI. Paul Finn is a world expert in MRI of the veins, and he works very closely with our group, and his group have developed many novel techniques for this, so that now we can use MRI to see these sort of clots that are developing anywhere within the body using no radiation and a minimum of contrast that could be potentially damaging to any other part of the body. And you can see here we're able to develop these 3D road maps of the veins, of the arteries. Here, rotate them around, coming up through the body, up to the heart and lungs, so that we're able to get a very good idea as to what your risk might be, and if we need to do any intervention, what the best way of doing that would be. Once we've imaged it, seen the clot, seen the problem, we need to decide what the best way of getting rid of it is. And there are 2 main ways that we go about that. The first is that we would use clot-busting drugs. The second is that we go and we directly remove the clot or break it up. That's called mechanical thrombectomy. And sometimes we do a combination of the 2, but oftentimes we choose one or the other, tailored, personalized to your particular needs and risk factors. How do we do lysis? Lysis is the other term for clot busting. How do we go about it? Well, what we do is we put a very small catheter, a very thin tube, like you can see here, coming up through the body here. A very thin catheter is placed into the vein, directly into the clot by an interventional radiologist. The way it would be for yourself, if you had a problem like this, is you'd come in. It's typically done as a one-night overnight stay. We place this small tube into the veins, directing along the line of the veins so that we're able to go with these valves. I would typically put the tube into the area of clot, for example, in the back of the knee, like we do here. And then we pass this very small tube, much smaller than a pen, navigating our way into the clot, around the areas that have been damaged, and up into your veins of your pelvis and chest. And then we put in this aggressive clot-busting agent that breaks up the clot over a period of usually 24 hours. And then the next day, we're hopefully finished. And we get these sort of results, where you can see here people who have big clots causing a lot of leg swelling. That's going to be very debilitating, very painful for them. We put in the medication, we leave it there overnight, we do what we need to do, and we're able to achieve marked reduction in leg swelling, marked reduction in pain. You can see this very nice lady who's a patient of mine a few months ago, 80-year-old woman who had very large right-sided leg swelling. She saw me in clinic 2 weeks later. Her legs were back to normal, looking much better, feeling much better, mobilizing, going about her business. Similarly, people who have very large, inflamed, painful, heavy legs can get very good results like you see here. If we don't want to use that clot-busting agent, or we think that it's better to use a different type of approach, then we have some different options to tell you about as well. These are what's called mechanical thrombectomy. The thrombus is removed, usually using a device of some kind. It's a more rapid way of doing it. We don't need that overnight stay that I talked to you about, so it can be done as a single session or indeed as an outpatient. There are some benefits as regards versus that clot-busting agent when people have clot for many months or many years. Sometimes it's not amenable to clot busting, but rather we're able to use these mechanical agents to break it up or suck it out. And sometimes we use a combination of the two, again, tailored to what the patient in particular needs and what we feel is appropriate for them. So we have a lot of different devices, a lot of different toys that we can use to remove these sort of clots, and I'm going to give you a quick flavor of just a few of them. This would be one of them here that we use pretty frequently. This is a small tube that we navigate into the clot, as you can see on the animation. When we're within the clot, we spray a very powerful spray of liquid directly out into the clot, which softens it up, relieves a lot of the pressure that's within the clot, and then we're able to pass it again, once it's been softened, to directly suck out the clot using a sort of vacuum sort of procedure. It's very effective, it works very well, and it could be appropriate in people who have either clots in the legs or indeed within the pelvis as well. Another device that could be appropriate is one that has a chopping up ability. This is for a clot that can often be quite thick, quite firm. We're able to move a device which will rotate around in an atraumatic way to the vessel in the clot, breaking up the clot, making it much smaller, allowing different medication or your body itself to start dissolving the clot safely. Other devices work more by suction. They're able to get the clot directly, suck at it, remove it from the vein and bring it outside of the body in a rapid way. We either have small caliber devices for use in veins below the hip or below the knee, or indeed larger ones then if you've got one of these big clots in the belly, in the pelvis, or in the heart and lungs itself. And we've developed quite an experience, our group, over the last few years in using these. So we've got a large and diverse ability and practice that we try and tailor this particularly to your needs. We have had good success. For example, this patient, a very sick gentleman who had a big clot here within the heart. This is the clot. You can see it bouncing around on this ultrasound of the heart. Very dangerous. If this clot were to move at all further within the heart, there could be further damage to the heart. Indeed, it could be fatal by blocking the heart and lungs completely. So we went in, we were able to suck on this clot using one of those devices as I told you about. And you can see here the pre and the post. The clot is completely gone. And indeed, here it is in my hand. Out in a filter, big, nasty clot, would have been very dangerous, probably would have killed the gentleman had it not been removed. So we fortunately have used this in many patients, and some of them have kindly gone on to spread the word about this, because we think that this is an important treatment that will hopefully benefit many other people. And so we have been able to use media to spread this out, and not only in this country, but also in other countries, and many people are now traveling to UCLA for this type of treatment. This is the sort of patient who may benefit from it. Someone who has a large volume clot, a big clot that goes all the way from the knees, all the way through the hip, all the way through the belly, all the way up into the main part of the abdomen. And this is a big clot. This is causing huge leg swelling, and we're able to go in. You can see here this picture of some of the clot that we were able to suck out, remove, big volumes of clot that otherwise would have been very difficult to treat just with drug therapy alone. So I wanted to give you a feel for where we are with DVT in 2016. What are the current problems we have with it? What are the current scope of treatment? And what are some of the nice things that we have to be able to treat it with? So if you remember, we thought that we'd talk about what is DVT and that it's clots within the veins, and they can occur anywhere in any vein, but most commonly within the legs. How big a problem is DVT? Huge. Huge problem. Million patients, million people in the United States this year, and a lot of them are going to go on to develop problems with ulceration in the future. We're going to try and prevent that using some of the techniques that we have discussed as well. And how do we go about treating it? Well, we go about treating it using the ABCs, ambulation, blood thinners, compression therapy, and then also some of the clot-busting drugs and devices that we described here today. So I'll stop there, but if you've any questions, you want to contact us either in person, contact us at any time at any one of our clinics here in Los Angeles at the phone number that you have there. And I'll hopefully be able to answer some of your questions from Twitter right now. Thank you very much. Great. So the first question here is, what is the difference between a DVT and a superficial venous thrombus? So this is a really good question, because this is an important thing that not everyone would recognize. You have two venous systems. One of them is the deep system. These are the big veins that I was talking about. They're the main trunk carriers of the blood. Then you have a more superficial venous system. They're the ones you can see in the back of your hand or in your legs. And they typically, when they develop clots, don't cause the problems of clots moving either to the heart and lungs, causing a PE, or clots leading to big-time leg swelling. They can cause other problems, but not to the same extent as a problem in the deep venous system, which are the real bulk of the problematic veins. Problems with the superficial venous system can go on to develop varicose veins or an inflammation, an infection, but again, they don't tend to cause the same level of problems, and we treat them in a slightly different way, typically with medication rather than with devices, although that is changing to some extent now. Next question, what things can I do to prevent DVT? Well, there are several reasons that people get DVT. One is that you have a genetic abnormality that you're born with. Unfortunately, there's not much you can do about that. But there are other things that can predispose you to having a DVT, such as stasis. In other words, if you're immobile or not able to move, if you're on a coach trip back to Ireland, sitting in the back of the plane for a long time, that can cause stasis and can cause you to be more likely to get DVT. So moving, making sure that you're active, that you're not either sitting in one position for a long time, or that if you do have a medical condition, that you are up and about as much as possible. These are very important when it comes to preventing DVT. Some people who have that genetic condition, some people who've already had a clot, should be on blood thinners to prevent further DVT. But the majority of people, it's keeping active, keeping hydrated. These are the important things for prevention of DVT. Next question, do DVT run in families? So yes, there are some families that have predisposition. There are certain conditions that you may have heard of, things like factor V, protein C, protein S. These are grouped together to be called the thrombophilia. We're lucky here in UCLA that we have a very active, very, I would say, internationally renowned group of hematologists who work with very closely with our group to make sure that people who have a genetic risk, people who have a familial history, that they are appropriately evaluated, and that we can make sure that not only them but their families, if necessary, are counseled so that we can help them prevent these problems before they even happen. Is there a risk of DVT or PE after a liposuction procedure? Well, yes and no. So yes, I would say that there is a risk of DVT or PE after any medical procedure. And that is because people are in bed afterwards, they're not moving around, they're perhaps in pain, therefore that they are staying stable without all the usual compression of the veins by the leg muscles that we like to see, because that's what keeps the flow going. However, while that is true, the risk with most procedures is as low as can be made by making sure that people are up and about as quickly as possible. If they need to be on blood thinners for the duration of the procedure, they are. And that importantly, if someone has a risk, either they've had a previous DVT or PE, then we are able to see that from the off, make sure that we are on top of it before, during, and after the procedures itself. And final question then is, when you see DVT in clinic, are there any concerns about people who need to have more than just this treatment? So that's true. Not everyone needs to have this treatment. But what we try and do is we try and make sure that the people who need to have this treatment get it. They get it in as quick and as easy a way as possible. And that people who don't need this treatment do not go ahead and have it. Therefore, we try and make sure that we see these people who have these conditions as part of a team. There's ourselves, our group of hematologists, our group of nurse specialists. We operate very much as a team to make sure we give the best, most personalized care to each individual patient. And I'll stop there. Thank you again for everything, and hope to see you again.